Welcome all to today's presentation. In this presentation, I'm going to tell you the story of saving lives in rural Bangladesh through a novel innovation implemented by Dr. Mahbubur Rahman and his team at ICDDRB. Bangladesh is one of the top 10 countries with highest neonatal deaths. Over the last 20 years, Bangladesh made a remarkable progress in reducing under 5 mortality, especially postneonatal and child mortality. But newborn mortality is still a big challenge and contributes 61% of overall under 5 mortality. Three quarters of the neonatal deaths occur in the first week of life and half in the first 24 hours, of which more than half occurs at home without any treatment and rest due to delayed care seeking. Now, let's know the global scenario of neonatal jaundice. Approximately 14 million neonates per year in LMIC develop hyperbilirubinemia, and 6 million of them need phototherapy but didn't get it. The highest burden of extreme hyperbilirubinemia are in sub-Saharan Africa and South Asia, which also includes Bangladesh. In Bangladesh, 50% of the delivery take place at home and only 2% of the newborn got any kind of postnatal checkup. Because hyperbilirubinemia is practically asymptomatic until brain damage occurs. Too often, newborns in rural Bangladesh present at hospital too late when phototherapy is no longer effective. Even after reaching at sub-district hospital, the newborn don't get the recommended treatment as most of the sub-district level hospitals don't have facility for phototherapy. There are cascading series of delays in the diagnosis and treatment, resulting in preventable disability and ultimately deaths. Clinic or hospital-based physical exam screening and referral to the hospital-based care is the current model of diagnosis and treatment of hyperbilirubinemia. In hard-to-reach area, government hospitals are too far for people to seek care. So, we proposed to shift the care from physicians and hospitals to community health workers and home. We proposed and implemented a CHW-led treatment model where CHWs will visit the household, screen the mother and newborn for danger signs, as well as will screen the newborn for jaundice with a transcutaneous bilimeter. They will provide either home treatment or will refer the baby to the hospitals. In this model, families will not have to travel to the hospital, wages will not be lost from having to accompany the mother to the hospital, the cost of nurses and physicians will be replaced with less expensive CHWs, and hospital bed cost will be eliminated. So, ICDDRB team formed a national level stakeholder committee with Ministry of Health and Family Welfare, neonatologists, obstetricians, academicians, and development partners. Together, they develop a community health worker training manual and a M Health platform to guide CHW in mother newborn danger sign assessment and neonatal jaundice treatment. The assigned CHW visited home, survey the family on the circumstances of birth, measure birth weight, determine gestational age based on last menstrual period and birth date with the assistance of this M Health tablet, and then they begin the hyperbilirubinemia screening protocol. The jaundice management platform is designed following American Academy of Pediatrics guideline, and it helped CHW to determine the treatment protocol based on physical assessment, newborn weight, gestational age, blood grouping and RH typing, and transcutaneous bilirubin level. The CHWs received 5 days theoretical and hands-on training on physical examination of mother and newborn, danger sign assessment, screening and management of hyperbilirubinemia. The CHW visit each newborn within 48 hours of birth and then daily for consecutive 3 days. and newborns who are eligible for home phototherapy are provided with LED phototherapy for 36 hours. Those who are eligible for hospital phototherapy have been referred to the hospital. Newborns and mothers who have any danger signs within this free visit were referred to hospital and received management. In our previous trial, through our recruited CHW, we were be able to screen 81% of the newborn by 48 hours and 89% by 72 hours. We have been able to reduce the incidence of severe hyperbilirubinemia by 89% in our intervention arms than the control arm. So, we are proposing to pilot this treatment model through a local NGO recruited CHWs who are working in hard to reach areas, so that this treatment model can be scaled up through government and local NGOs in futures. We believe children's prize funding will help us to achieve our goal. Along with others working in newborn health, we also believe to invest in care at birth and reap a triple return. Thank you for your patience hearing.